My name is once again is Lori Mantefel. I'm with Metastar, and we'd like to welcome you all in joining us for our informational webinar about the new Intuit project, improving non-surgical treatment for urinary incontinence.
We're not going to go around and do introductions for everyone, but I'm Joan Neuner. I'm a general internist with a practice at the Medical College doing primary care, Medical College of Wisconsin in Milwaukee. And Heidi Brown will be taking over halfway through this presentation. She is one of the other multiple PIs. She is a urogynecologist at UW-Madison. Not here today, but here in spirit is Catherine Flynn, who is another MPI with us. And Mona Matthews, you will see her face from Metastar, as well as Lori. So with that, I'm going to jump right into a little bit of an introduction into the problem of urinary incontinence. And I'm sure people on this call are aware of how much this can affect patients, but I did want to just show you with one slide that you're right. This is really important to patients and very, very prevalent. So over 50% of adult Wisconsin women have urinary incontinence. Men are a little behind. Our focus today will be women. And that's because that's what the funder says. But this is really a problem for many older adults. And in the case of women, most older women. This therefore has even higher prevalence in diabetes or obesity. And unfortunately, incontinence has been normalized in many populations in the US, so that many patients who ask their friends or their family are told that no, this is a normal part of being older or having children, so they don't seek help from either primary or specialty care. Nonetheless, other studies have said that actually patients do want us to ask about it, they just don't want to bring it up themselves. But as you all also know, we have limited time and lots of demands on our resources and lots of other things that we are trying to help patients with. So that with that perspective, we have, I sort of wanted to show a little bit in the next few slides about my reasons for joining this project and really starting to think a lot more about incontinence in both my own clinical practice and research that I'm involved with. And working with Heidi and Catherine Flynn, who had been doing this for years before me, I was starting to think about incontinence and then was mortified when several patients came in the next month after I started to write a grant wearing full brief dependence, incontinence undergarments that I had no idea needed that level of help and had never told me that they were having incontinence. Around the same time, my institution started to really sort of advertise use of annual wellness visits and incentivize them for us. So I started doing more and more of those, older patient prevention visits, physicals, but as you know, they're not physicals. And we had a screening question about incontinence in our annual wellness visit template. And I was seeing so many patients who just by being asked directly, in a one question format from me in the office, were saying, yeah, I've been struggling with this for a while. But what about those who don't make an annual wellness visit appointment, and how can we streamline help for very busy primary care doctors who are uncovering this along with lots of other things at those visits? So at the same time, what I was realizing is that in the past, I had felt like there were somewhat complicated and maybe even a little bit of contradictory guidelines from different groups about how much workup I needed to do to figure out, to start to help these patients. But as I dug into this, I realized, and I want to tell you that the specialists even have really simplified, I think for two reasons. One is they haven't been able to show that doing extensive testing early is really beneficial to patients. And the other is that they have been able to show that early interventions are helpful to many, many patients. So here's an example for urge incontinence from one of the AUA, American Urologic Association, guideline on urge or urgency incontinence. And really they say, ask patients, do your usual history. And if you haven't done a urinalysis lately, do that. But even in their office, they don't always say that you need to get a bladder diary, and they certainly don't recommend for us that we do anything like post-void residuals. So I think that some barriers that I perceived were there a few years ago really have gone away as the evidence on this and the expert opinions have changed in ways that can really help us do briefer but very helpful interventions with patients. So next slide. And then I actually just did want to say, I'm sorry, Stress incontinence, actually, the guidelines are not exactly the same, but really, again, similar in terms of you can really start things in the office after a history, a brief physical, and thinking about whether you need a urinalysis today or if you did one 2 weeks ago. And, as a corollary or related, as I mentioned earlier, part of the reason I think to intervene early without a lot of extensive workup or necessarily doing referrals right away is that there is really good evidence for some behavioral self-management. And these are some examples from my meta-analysis that was done and published in the Annals of Internal Medicine a few years ago, which showed that behavioral treatment for urgency incontinence was very, very effective. And in fact, while anticholinergic medications work as well, they don't work as well as behavioral treatments. And then the most effective thing is using them both together, which has been shown when you compare that to just anticholinergic medications alone. And there's a similar story to stress urinary incontinence, where the behavioral treatments were slightly different for these different types of incontinence. And then, as you know, there can be mixed, but very extremely effective. And hormonal therapy was essentially topical estrogen. And that combination has been really effective for patients. And finally, that my next realization is that I'm not usually, in addition to not having the time, I'm not actually usually the most effective person to teach them these behavioral techniques. And so the existing resources and referring to those resources can really limit the burden on primary care practices so that you don't feel like you're opening Pandora's box. You've got something you can help patients with. And specifically in-person or virtual classes. So this doesn't have to be one-on-one to start for many patients, or free or low-cost videos, free videos, and low-cost classes that teach behavior change work for lots of patients, and work to the level of either dry or quite satisfied because of significant improvement. Now, for patients who they don't, there's even extremely strong evidence for the role of pelvic floor physical therapists in both urgency and stress incontinence. And if needed, or at the same time, there are specialists who can certainly help you with pieces of this. And part of our project is to help make it a lot easier to connect with those continence care specialists, which are usually urologists, urogynecologists, or obstetrician gynecologists. And I did just want to do a shout out for what do I mean by these resources that are out there. So this is the schedule for what's available this summer in one specific free or low cost workshop, which is available either online or in certain county on aging centers across Wisconsin. So you can see Eau Claire's here, an online one, and one in Ripon. And this is called Mind Over Matter. It's a 3-session group class that has shown really excellent outcomes. And I've started referring many of my patients to these classes, and this is the kind of thing that we hope in this project to help facilitate for you.
So we're really excited to have this funding opportunity to really direct some resources to Wisconsin primary care practices to support them in managing urinary incontinence in women. And by way of background, Evidence Now is a funding initiative of the Agency for Healthcare Research and Quality that is focused on supporting primary care to implement guideline-based care into their already very busy lives. The first Evidence Now initiative focused on advancing heart health, and with subsequent iterations, the goal of these Evidence Now projects is that we learn not just how to support primary care in implementing practice improvement around a particular issue like heart health or unhealthy alcohol use, but also that we're learning about the process of quality improvement or practice improvement in primary care so that primary care practices can use the principles that are learned through the Evidence Now initiatives to undertake whatever quality improvement initiatives are important to independent practices. So we could not have been more excited when this funding opportunity was announced about 1.5 years ago now, that Evidence Now was going to focus their most recent funding cycle on managing urinary incontinence in adult women. So our grant as a research site is a 3-year grant from AHRQ. And during that time, we are enrolling practices and then Each practice engages in a 6-month kind of intensive participation, and then we follow a practice for a year beyond that to see what happens once we're not intensively engaging. The research partnership has 3 components: UW-Madison, the Medical College of Wisconsin, and Metastar. And we're focused on supporting primary care practices across the state to adopt an intervention called UI Assist, which is a very simple intervention to help screen for, diagnose, and manage urinary incontinence in primary care. It's based on really core principles of delivering evidence-based education and community building and providing virtual QI support and technical assistance, minimizing the burden on practices and maximizing the value. We're really proud because they only funded 5 sites across the country for this initiative, and we're one of them, even though they already had 2 other Midwest sites funded. And we think one of the big reasons that we were funded is because our project is not just focused on one well-resourced health system, but rather we're trying to reach out across the state and engage with practices in diverse settings and with diverse practice patterns so that we can figure out how to support not just the well-resourced primary care practices, but all primary care practices. The overarching goal of our project is to ensure that primary care practices have the support and resources they need to manage urinary incontinence in adult women patients. And we're collecting a little bit of data for our research question from patients and from practices. The information that we would collect from participating practices patients is some basic survey questions of patients about whether or not they recall having been screened for incontinence and whether or not they were offered treatment if they did screen positive for incontinence. We will support participating practices to pull some very basic diagnosis reports from the electronic health record to look at whether or not, as a result of participating in this project, practices are more likely to diagnose urinary incontinence. And then finally, we are going to ask participating practices to share a little bit about their experiences implementing and maintaining the program, because of that overarching goal of evidence now, not just to do the project of the moment, but also to identify what worked well and what didn't work so well to inform future quality improvement initiatives for primary care. So what is UI Assist exactly? It's essentially a 3-step process to help busy primary care practices screen for and manage urinary incontinence in women. And it's based on practices that have already been proven to be efficient and feasible in primary care. And we're using a menu-based approach for easy tailoring. One of the things that we learned in prior iterations of Evidence Now is that primary care practices do not have time to engage in very long, resource-intensive practice facilitation. And so what our team has done is used our expertise in implementation science to really build a very brief menu to support practices to identify how they can incorporate screening for incontinence, educating patients about the prevalence and treatability of incontinence, and assisting patients with accessing solutions through managing in primary care or referral to partners. And during the project, our team works with various members of the participating practice to identify what already works well in the practice, what works with practice flow, and how can we incorporate screening for urinary incontinence, patient education, and patient management. So what does participation in this project entail? We do ask a participating practice to identify a practice change team, which is anywhere between 2 and 5 folks in the practice, both providers like physicians, APPs, PAs, and staff like medical assistants, schedulers, nurses, who work together with our project support team to select and implement the best components from that menu to screen for and treat urinary incontinence in that practice. The project team provides free practice facilitation to the practices and partnership building support to half of practices. And that's because one of the research questions that we're testing is whether practices are better able to screen for and manage urinary incontinence if they have the supplemental support of partnerships with local community resources. So half of participating practices will be randomized or randomly assigned to this additional support. Each participating practice will receive a stipend of at least $2,500 to the practice to thank you for your participation. And we do ask you to participate in minimal data collection activities. So what does participation look like? In the month prior to project launch, which is the planning phase or the blue phase here, the practice change team engages with our quality improvement project support team to personalize that UI assist menu for the individual practice and to make a plan of attack. During the dark green implementation phase, which lasts 6 months, the practice is then implementing whatever the practice change team identified as being the best for that practice. During that 6-month period, we have 3 practice meetings where we give education, get feedback from the practice about what's going well and what's not going so well, and revise so that hopefully by our celebration visit at 6 months, your practice feels comfortable with what you've selected and is ready to continue doing it. During the following 12 months, the light green maintenance phase, we will interact with you very briefly about 3 times over that 12-month period to just check in and see what's happening, whether or not the changes actually stuck and became part of your new normal. What does the practice receive for participation? 5 hours of free practice facilitation to tailor that streamlined quality improvement plan focused on urinary incontinence in this project, but also potentially giving you kind of the roadmap for how you do it for other conditions. A curated list of local resources that are specific to your community, which includes specialists like physical therapists, occupational therapists, community organizations that can support your practice in delivering urinary incontinence screening and treatment. Access to physicians in primary care and urogynecology like Joan and myself with expertise treating urinary incontinence. Access to an online community of other practices in Wisconsin that are also participating in this project and maybe navigating similar hurdles. A practice stipend of at least $2,500. Do we say that again? That we're going to pay you to participate? So thank you for your participation. And there are opportunities to make participation in this project count towards your practice improvement or quality improvement requirements for maintenance of certification with the American Board of Family Medicine or Internal Medicine. I did mention that part of participation is minimum data collection activities. So during the 3 practice meetings, during the 6 months of active participation in the project, we will ask folks to share their feedback, and that's one of our data collection time points. We'll also support your EHR folks in pulling quarterly reports so that we can look at whether or not the rate of diagnosis of incontinence changes as a result of participation. We will ask the practice change team to help us coordinate some anonymous patient surveys before and during the implementation to see whether or not we moved the needle in screening patients for incontinence. And we'll also ask your practice to post flyers in clinic bathrooms and common areas to increase awareness about incontinence and the project. The benefits to your practice are the monetary compensation, the opportunity to achieve better bladder health for your patients and really improve patient satisfaction. It's amazing. You know, there are a lot of things that we do where we don't see a direct improvement, but this is one where when patients come back and they're able to get through the night without wetting, they're really grateful. And there's an opportunity to choose QI processes that limit practice burden in this project that you can then use for other QI initiatives. We can support MOC for your providers, and participation will definitely support building and strengthening connections with existing local resources. To be eligible, practices should be located in Wisconsin, offer primary care services to women, have an electronic health record without plans to change platform during the time of participation, be willing to work with a practice facilitator in our project support team, and be willing to be allocated to the partnership building arm or practice facilitation alone, since there is a randomization at the practice level.